My name is Mina Popovic, and I'm a clinical embryologist with a background in genetics. I'm currently the scientific director of the Eugin Group and also a professor at the Department of Reproductive Medicine at Ghent University in Belgium, and I live in Barcelona in Spain. My research focuses on early human development with a particular emphasis on chromosomal instability and implantation success. And what particularly drives me is the challenge of translating laboratory discoveries into tangible clinical improvements. And I currently lead several international initiatives and industry collaborations that are focused on bridging this gap. PGTA's primary objective should be to identify and deselect embryos with chromosomal abnormalities during IVF. Embryos with chromosomal abnormalities typically face one of three outcomes. They either fail to implant in the uterus, or if they do implant, they often lead to a miscarriage, or in rarer cases, they could result in the birth of a child with a chromosomal disorder. So by removing these embryos from consideration, PGTA acts as a filter. It helps streamline the IVF journey by preventing predictable failures. And in doing so, PGTA may reduce the time needed to achieve a pregnancy, and it can also minimize the emotional and financial burdens that are associated with multiple failed transfers. I do believe that there is often a disconnect between what PGTA actually does and how it is presented to patients and even medical professionals. Many clinics market PGTA as a way to select the best embryo or to improve success rates. And in my opinion, this creates unrealistic expectations. What we should understand is that PGTA's real strength lies in identifying embryos that have virtually no chance of success. PGTA does not make embryos better, and it cannot create more successful embryos. It just helps avoid predictable failures. And this can potentially save time and reduce the emotional burden of having unsuccessful transfers. What I would like patients to understand is two key points. Firstly, while PGTA improves success per embryo transfer, it cannot improve overall success. So if all embryos were to be transferred eventually. So it can just help to achieve a pregnancy faster by avoiding the transfers that will not work. Secondly, chromosomally normal embryos are not guaranteed to succeed. And in fact, about 30 to 40% still do not result in a pregnancy. So really, PGTA is about improving efficiency in the IVF journey, not the ultimate chance of success. So being clear about this is very important, and it can help patients make better informed decisions about whether PGTA is right for their situation. So while PGTA does offer clear benefits, in my view, it faces two significant limitations, and these are genetic testing laboratory variability and technical challenges. And these are particularly important when we talk about more complex results such as chromosomal mosaicism and segmental abnormalities. So the lack of standardization across genetic testing laboratories is particularly concerning. Our research, for example, has shown that rates of mosaicism can vary from 3% to 25% across different testing facilities. And this is simply due to the different diagnostic thresholds that they apply for diagnosing an embryo as mosaic. And some labs classifying an embryo as mosaic if they determine 20 to 80% of the cells within the biopsy to be abnormal, while others use a threshold of 30 to 70%, for instance. And what this can mean is that identical embryos may receive different classifications depending on where they're being tested. Also, technical challenges do create uncertainty. What we have to keep in mind is that we are testing very limited amounts of DNA from the embryo, and the whole genome amplification process that is required to amplify this material for testing can introduce artifacts, and these can mimic chromosomal mosaicism or segmental abnormalities. And of course, we are only analyzing just 5 to 10 trophexidome cells, and these may not represent the entire embryo's chromosomal status. So what is very important to realize is that these limitations can have real clinical consequences. And this is why it is crucial to work with experienced, validated genetic testing laboratories that have strong quality control processes. So while PGT-A is reliable for detecting clear chromosomal abnormalities, there is still significant uncertainty when it comes to diagnosis of mosaicism and segmental abnormalities. So what we urgently need is better standardization across laboratories, clearer guidelines for interpretation and reporting, and also more transparency into how results are being reported. So the key to using PGT-A properly lies in understanding its primary value, which is identifying embryos that have virtually no chance of success, rather than selecting the best embryos. And when we use it for its primary value, PGT-A functions effectively as a diagnostic tool, and its results are highly reliable when the testing is performed by validated laboratories. The concerns about PGT-A's reliability often arise when we try to extend its use beyond this core strength. And this is why standardization in the field is crucial. It would really help maintain the proper use of PGT-A as a diagnostic tool for its intended purpose, which is the identification and exclusion of embryos with clear chromosomal abnormalities that are destined to fail. Yes, but our confidence depends on what we are attempting to diagnose. If we speak about uniform whole chromosome aneuploidies, we can and we should use these results to exclude embryos for transfer. Research has consistently shown that abnormal embryos have extremely low reproductive potential and are ultimately destined to fail, especially those with whole chromosome aneuploidies. As for diagnosis of chromosomal mosaicism, there still remains a serious question about whether we should be reporting these at all, especially given their low predictive value and the lack of standardization across laboratories when making these types of diagnoses. Embryos with clear, uniform whole chromosome aneuploidies should not be transferred. The positive predictive value of these diagnoses is exceptionally high, so these results should be considered to be highly reliable, and these embryos are known to have very low reproductive potential. They will either fail through failed implantation, they could lead to a miscarriage, or in rarer cases, they could lead to a birth of a child with a chromosomal disorder, and we should avoid these predictable failures. The diagnostic accuracy for uniform whole chromosome aneuploidies is very high when performed by experienced laboratories. And a decrease in cumulative live birth rates is more likely to be related to the way in which we handle diagnosis of chromosomal mosaicism or even segmental abnormalities, not to the misdiagnosis of clear whole chromosome aneuploidies. And this again emphasizes why we should focus on PGT-A's core strength, which is identifying and excluding embryos with clear whole chromosome aneuploidies. These are the embryos that are highly likely to fail. The reporting of mosaicism in PGT-A presents a significant challenge in our field. While we can detect intermediate copy number profiles that suggest mosaicism, several crucial issues make reporting mosaicism controversial. First, there are important technical limitations to consider. So the detection of mosaicism is highly dependent on thresholds and technical factors, such as amplification artifacts and sequencing noise. And this is evidenced by the striking variability that is observed in reporting of mosaicism across different genetic testing laboratories, which can range from 3% up to 25%. And these variations really suggest that what we identify as mosaic may often actually be an artifact of the testing process rather than a true biological phenomenon. Secondly, we face significant challenges with clinical validation. So while PGT-A can detect these intermediate profiles, their clinical significance remains unclear. Research has shown that many embryos that are labeled as mosaic can actually lead to healthy live births, and this challenges the assumption that all detected mosaicism is somehow harmful. So by reporting these findings, we can actually risk excluding embryos that may have resulted in successful pregnancies. And this is particularly concerning for patients with limited embryos available for testing. Important thing to remember is that reports of mosaicism in PGT-A appear to be dramatically higher than what we see in nature. So if we compare the prenatal testing data where true fetal mosaicism is around just 0.2%, it raises a serious question. Are the embryos that we are diagnosing with PGT-A truly mosaic, or are we introducing a high false positive rate due to the limitations of the biopsy and the sequencing process, and also the thresholds that we are setting for diagnosing mosaicism? And ultimately, what it comes down to is about weighing the trade-off. If we discard embryos due to uncertain mosaicism findings, how many potentially viable embryos are being lost? And what is the actual risk of transferring them? Current data suggests that the risk of adverse outcomes for transferring low-grade mosaicism is very low, whereas the alternative, which is discarding embryos, may significantly reduce a patient's chance of pregnancy. And to me, this is not a fair trade-off, especially for patients with very few embryos available for testing. And this is why patients and clinicians should fully understand the limitations of PGTA in detecting true chromosomal mosaicism before making any clinical decision. Regarding concerns about persistent mosaicism in offspring, it is important to put this in perspective. So case reports of persistent mosaicism following PGTA diagnosis of mosaicism are extremely rare. I think it's less than 0.05% compared to the large number of healthy live births from both tested and untested embryos. And also, without routine genetic testing of all IVF and naturally conceived children, we don't even know the true baseline rate of chromosomal mosaicism in the general population. And this makes it very challenging to contextualize the significance of mosaic embryo transfer outcomes. The current situation also leads to inconsistent clinical management. There is still no consensus on how we should prioritize or counsel patients about mosaic embryos, especially when we get into details regarding the chromosomes involved or the level of mosaicism that we detect. And this leads to variable practices across clinics. And additionally, when we report uncertain findings, this can cause unnecessary stress for patients that are already trying to make difficult decisions about their treatment. So given these issues, I believe there is a strong argument for not reporting mosaicism, especially diagnosis of low-level mosaicism, at least until we have a better clinical validation and standardization. Instead, we should focus on PGTA reporting on clearly abnormal and clearly normal results, where we have more confidence in the clinical implication. The KPIs for PGTA should be based on or build on both the analytical and clinical validations that we should perform for each platform. And that these should reflect the core function of PGTA, which is, in my opinion, identifying embryos with clear chromosomal abnormalities, those that are destined to fail. And I'll talk about these very generally, as I think this could be a whole topic in itself. So for analytical validation, positive predictive value is very important. So it measures the probability that an embryo that's diagnosed as aneuploid based on a trophectoderm biopsy is truly aneuploid in all of its cells. We can also look at quality control metrics to ensure a technical reliability of the testing process, laboratory performance indicators, which are crucial given the impact of laboratory expertise on results. And from a clinical perspective, we can focus on live birth rates per transfer and the time to pregnancy, which really reflects our efficiency in avoiding failed transfers. And an interesting one is looking at the proportion of cycles with transferable embryos. And this can ensure that we are not over discarding viable embryos, which can ultimately be also measured by looking at cumulative live birth rates. But of course, this is more challenging. I chose these metrics because they align with what I believe is PGTA's primary objective, which is really deselecting embryos with no chance of success. But what we should keep in mind is that different patient groups may see varying benefits from PGTA, which is why these metrics must be evaluated across different populations and different maternal age groups. So the embryo biopsy procedure does carry some risks, but these can certainly be minimized with proper expertise and training. These risks can be higher for poor quality embryos, which are inherently more fragile. However, the skill of the embryologist does play a crucial role in minimizing any harm. So, for instance, studies have indicated that embryologists that perform more than 50 biopsies per year achieve better outcomes. And this highlights really this importance of experience, technique, and training. So beyond the procedure itself, quality control within the laboratory is also essential. So as I already mentioned, proper preclinical and clinical training, but also strict handling protocols, also careful storage of samples is critical to reduce any risk of contamination and errors. One useful metric, in fact, for assessing laboratory performance is the rate of inconclusive results, so no calls, which should typically remain below 2.5%. We can even look at the rate of chromosomal mosaicism per clinic or per operator, which of course should be kept within acceptable limits. The answer really depends on the patient's individual circumstances. For some patients groups, PGTA can certainly offer clear benefits, especially if performed well and by validated laboratories. It can significantly improve live birth rates per transfer. Especially this can be important for women of advanced maternal age or those experiencing recurrent pregnancy loss, for instance. However, in younger patients and in good prognosis patients, the benefits can be less clear. PGTA can lead to the unnecessary discarding of embryos with uncertain but potentially normal results. And here a major issue is the lack of standardization across genetic testing laboratories, particularly when it comes to diagnosing and reporting mosaicism. And these inconsistencies can really lead to vastly different clinical decisions. And this can ultimately result in some clinics inadvertently discarding far more embryos than others purely based on reporting differences. Another very important factor to consider is the financial and emotional factors associated with PGTA. Of course, PGTA adds significant costs to IVF, which may not be justified for all patients. However, for some, the peace of mind that comes with avoiding failed transfers can outweigh the financial burden. And this balance, of course, varies depending on healthcare systems, individual patient priorities, and of course, significantly, the patient medical history. So overall, in my opinion, PGTA is a valuable tool when used well and when used appropriately. However, in order to maximize its benefits, while we minimize unnecessary embryo loss and maximize transfer opportunities, we need to really strive for better standardization in the industry, careful patient selection, and strict validation of both clinical and laboratory procedures. Educating patients about PGTA requires a careful balance between explaining its benefits and being very transparent about its limitations. The key is to help patients understand that PGTA's primary value lies in identifying embryos that have virtually no chance of success, rather than selecting the best embryos. And this distinction is very crucial for setting realistic expectations. So when counseling patients, we need to be very clear about what PGTA can reliably do. It can help them avoid predictable failed transfers and miscarriages. And by preventing these failures, it may help reduce the time to pregnancy and the emotional burden of unsuccessful transfers and miscarriages. However, we must equally emphasize what PGTA cannot do. It cannot guarantee a successful pregnancy, even with a normal result. It cannot create more viable or more successful embryos, and it doesn't improve overall pregnancy rate if all embryos were to be eventually transferred. Of course, different patient groups may need different counseling approaches. So for patients of advanced maternal age where aneuploidy rates are higher, the benefits of PGTA may be more apparent. However, patients with fewer embryos available for biopsy need to carefully weigh the risk of biopsy and potential inadvertent embryo loss. Young, good prognosis patients may not see significant benefit, and these should be also clearly communicated. Another aspect to be discussed are the technical aspects, and these should be made clear to the patients in an accessible way, so patients should understand that the biopsy does carry some risks, and that the results heavily depend on laboratory expertise. And this is why working with experienced, validated laboratories is crucial. Patients should also understand that some results may be inconclusive or uncertain, particularly when it comes to findings such as chromosomal mosaicism. And the goal of this education should really enable truly informed decision making. This includes not just considering the medical aspect, but also the emotional and financial implications of their choice. So by providing these comprehensive but clear information, we can better manage patient expectations. And this will ultimately lead to an overall better patient experience, regardless of their choice about PGT-A. So looking to the future, I believe the most valuable advances won't necessarily be in improving PGT-A itself, but rather in developing complementary tools that could help with the positive selection of embryos. So while PGTA today can tell us which embryos are chromosomally normal, it cannot tell us which of these normal embryos are most likely to succeed. Remember that about 30% of chromosomally normal embryos still do not implant, and even less actually result in a live birth. So what we really need are tools that can help us understand why some euploid embryos succeed while others fail. And these may come from advances in understanding embryo developmental dynamics, embryo metabolism, gene expression patterns, or other markers of developmental potential. What I would like everyone to understand is that there is still so much we don't know about human development. And this is where my interests are as an embryologist and a researcher, to really understand why high-grade euploid blastocysts fail to implant. And we are developing several studies around that. However, it is critical to remember that as these new technologies will inevitably emerge, we should maintain a critical approach, an approach that we may have learned from the implementation of PGTA, that it is very important to be very clear about what each test can and cannot tell us, and that we ensure proper validation, both analytical and clinical validation, before we implement these tests into clinical practice.